Today we will be discussing polycystic kidney disease. Basically, it is also a tubular disorder. We have already discussed renal tubular acidosis and tubular interstitial nephritis. Polycystic kidney disease is an important entity and is an important cause of end-stage kidney disease. So we will be discussing the different types of polycystic kidney. Basically, polycystic kidney disease is an inherited disorder. Here, for example, in glomerular, we had got Alport syndrome, which is an inherited disorder, or thin membrane disease, again an inherited disorder. In tubular disorder, the genetic disorder is called polycystic kidney disease, in which multiple cysts develop in the kidneys. World Health Organization has classified into two distinct disorders, which are autosomal recessive polycystic kidney disease, ARPKD, and autosomal dominant polycystic kidney disease. These are the two distinct type of uh, disorders. But in addition to this, we have to discuss the differential diagnosis of different types of cystic diseases of the kidney. But before that, let's see what is polycystic kidney disease. It's a genetic disorder that I have already told you. It runs in families. Somebody in the family is affected because and is transmitting disease to the children. A genetic disorder can happen if one or both parents pass abnormal genes to their child. Genes are the basic element of heredity. At conception, children receive a set of genes from each parent. They determine the characteristics such as hair color and eye color. I am sure you must have read genetics, some form of genetics. Genes can also determine the likelihood of developing disease. The passage of abnormal genes to a child can be through dominant inheritance or recessive inheritance. Now, what is dominant inheritance? If one parent has the disease and passes an abnormal gene to the child, it is called dominant inheritance. For dominant inheritance, one of the parents has to be infected with the disease, and father or mother passes the genes to the abnormal genes to the child. There is a 50% chance of getting the disease. The risk is same for every child, regardless of how many children develop the disease. Now, the normal genes, unaffected parent, and affected parent, abnormal genes, PKD1 or PKD2. Now, children receive a set of genes from both parents, father and mother. The affected child with the polycystic kidney will inherit one normal gene from the unaffected parent, but abnormal gene, either PKD1 or PKD2 from the from the other parent. And the unaffected child, there is a 50% chance the unaffected child receives a normal gene from both the parents, affected as well as unaffected. So there is a 50% chance of having disease in autosomal dominant polycystic kidney disease. Recessive inheritance. In recessive inheritance, both parents carry the abnormal genes. They are not infected, they are not suffering from that disease, but they carry the abnormal genes. And both of them pass an abnormal gene to the child. It is called recessive inheritance. The chances of getting the disease in a child is 25% as compared to 50% in autosomal dominant. This was very briefly about the autosomal dominant and autosomal recessive. Again, a diagrammatic representation, unaffected carrier, both are unaffected carrier, and they both carry abnormal genes. Now, they pass a set of genes to their offspring. Unaffected, 1 in 4 chances, unaffected, unaffected, and affected, 1 in 4 chances. There is a 25% chances of getting the disease. Now, WHO, according to WHO classification, autosomal recessive polycystic kidney disease, ARPKD, there is a mutation on chromosome 6, resulting in bilaterally equal size cyst. There is invariable hepatic involvement. There are cyst and hepatic impairment in autosomal recessive disease, and they present at birth or in early childhood. According to WHO classification, autosomal dominant polycystic kidney disease, ADPKD, is a serious disorder. There is mutation mostly on chromosome 16, which is 85%, or maybe on chromosome 4, which is 15%. There is alteration in gene protein polycystin 1 and gene product PKD1, or gene protein polycystin 2 or gene product PKD2. The feature is bilateral varying size cyst, multiple extrarenal manifestations, and they usually present with signs and symptoms above the age of 30 years. Autosomal recessive, a disease of infancy and childhood. Autosomal dominant polycystic kidney disease is usually in the adulthood. Presentation is in the adulthood. Now, before proceeding further and discussing autosomal recessive and autosomal dominant, we need to identify certain other form of cystic diseases of the kidney. You just have to remember the name, and basically these are not serious disorder, but you should be able to identify the different types of cysts in the kidney. The differential diagnosis include multicystic dysplastic kidneys, obstructive cystic dysplasia, medullary sponge kidneys, benign renal cyst, or acquired cystic kidney disease. Now, the most important thing to remember is that in both autosomal dominant and autosomal recessive polycystic kidney disease, both the kidneys are injured. But in these cystic disorders, made with multicystic dysplastic kidney, obstructive cystic dysplasia, medullary sponge kidney, benign renal cyst, or acquired cystic disease, the cysts are not usually bilateral. They usually involve one kidney. Rarely both kidneys are involved. So this is one of the most important differentiating point between polycystic kidney disease and other forms of cystic disease, other forms of cystic disease. Now, in multiple dysplastic kidney, there is renal dysplasia with multiple cystic dilatation of the nephron. Nephron is usually the tubular structure, and most important is the distal tubule. During the embryonic development, in utero, there is a cystic dilatation because of dysplasia, cystic dilatation of the distal nephron. The etiology is unclear, sporadic occurrences are there, and there is a rare family history. Presentation is at birth or childhood, rarely symptomatic, may impair urine output. Mostly unilateral cyst of varying size on ultrasound. The other disease is obstructive cystic dysplasia. There is again a renal dysplasia with cystic dilatation secondary to fetal urinary obstruction. Ureteral stenosis. If there is a ureteral stenosis in the fetus, it can lead to renal dysplasia and cystic dilatation. Presentation is at birth or early childhood, asymptomatic in mild cases, and it can result in acute kidney injury in severe cases. Since there is ureteral stenosis, the child is not passing out the urine into the amniotic fluid, so there is oligohydramnios. That is during pregnancy. Ultrasound shows unilateral bilateral cyst of varying size. Treatment is surgical elimination of the obstruction. Medullary sponge kidney are calcified cysts originating from the papillary collecting tubules. It is congenital sporadic, usually asymptomatic and is incidental finding. Hypercalciuria, recurrent UTI, nephrolithiasis are common. If they are bilateral, which they are very rarely, it can lead to chronic kidney disease. Diagnosis is by ultrasound. Prophylactic treatment is of nephrolithiasis with thiazide diuretics. They help in excretion of the calcium. This is the ultrasound of medullary sponge kidney. Lot of calcification in both the kidneys. Benign renal cyst. Again, they can be solitary or multiple renal cyst, made mostly in the one kidney. It is also an incidental finding on ultrasound or CT. Round oval anechoic cyst. That is, the cyst has got only clear fluid in it, minor reduction in sound wave intensity due to clear fluid in the cyst. If ultrasound finding is unusual, for example, if you find echoes of thickened cyst wall, it can point towards malignancy. The rare complication is rupture of the cyst resulting in pain, infection, and compression of the adjacent tissue. If symptomatic indication for surgery, example, pain and obstructive urine flow. But most of the time, these are benign. They only cause occasional renal colic and no need for any surgical intervention. This is a benign renal cyst with clear fluid in it. Acquired cystic kidney disease, ACKD. ACKD can happen in kidney with long-term damage and severe scarring of it. It usually happens in those kidneys which are already damaged. Often seen in patients of end-stage kidney disease who are on dialysis. For more than 5 to 10 years on dialysis, they do develop acquired cystic disease. 90% patients are on dialysis more than 5 years, may bleed in urinary system and cause hematuria and pain. Only symptomatic treatment is given, analgesic and spasmodic. Now we come to the main important two, polycystic kidney disease, which is according to WHO classification, autosomal recessive polycystic kidney disease, ARPKD. It's a recessive form of PKD we have already discussed, associated with congenital fibrocystic system cysts in many places on the body. Mutation on chromosome 6, PKHD gene 1. Remember chromosome 6. Features are it appears early in the childhood and the child usually have short life expectancy. The prevalence is 1 in 20,000 live births. They usually present with protuberant abdomen because of enlarged kidneys, abdominal discomfort again because of enlarged kidney, abdominal masses and hepatomegaly, polyuria, polydipsia, hematuria, and proteinuria. Hypertension is a feature in these patients and shortness of breath because of long stint. Hypertension leading to heart failures. Diagnosis of autosomal recessive polycystic kidney is by an ultrasound, usually and should be performed in perinatal and neonatal stages. It shows enlarged kidneys, bilateral multiple cysts with clear fluid in it, and hepatic cysts are also identified. They usually die early in the childhood. If they progress, the usual lifespan is 15 years after developing end-stage kidney disease. Deterioration in liver function and respiratory insufficiency are important complications. This is the ultrasound showing multiple cysts in the kidney, clearly with clear liquid in it. The extrarenal manifestations of autosomal recessive polycystic kidney severe in utero renal impairment resulting in oligohydramnios and Potter sequence. Since they are not producing urine and that they are not passing urine into the amniotic fluid, the characteristic feature develops which is called Potter syndrome. Basically because of oligohydramnios. They have craniofacial abnormalities, clubbed fleet, pulmonary hypoplasia, and respiratory insufficiency. Liver involvement lead to portal fibrosis, portal hypertension, and liver failure. Hypertension difficult to control, resulting in congestive cardiac failure. All are serious consequences. Bilateral renal agenesis or bilateral multicystic dysplastic kidney or autosomal recessive, any form of the polycystic kidney disease which is bilateral, reduced fetal urine excretion, oligohydramnios causing fetal compression, resulting in Potter facies with low set ears, beak, nose, prominent epicanthic folds, and downward slant of the eyes. Pulmonary hypoplasia, causing respiratory failure and limb deformity like club feet. This is a typical photograph of Potter syndrome. Low set ears, beaked nose. The treatment of autosomal recessive kidney is you have to do mostly symptomatic treatment like treat hypertension, symptomatic treatment for pain and dialysis if end-stage kidney disease. And most of them do require dialysis in early childhood. Neonates with severe cystic dilatation, the prognosis is poor, rarely survive more than 1 month. The majority of children who survive infancy have a life expectancy of around 15 years, but have they are on hemodialysis because of end-stage kidney disease. Prognosis depends on the extent of renal and hepatic involvement. Now we come to autosomal dominant polycystic kidney disease, ADPKD. This is a very important disorder. It is inherited form of disease. The prevalence is quite high, 1 in 1,000. Reduced life expectancy in childhood, typically presents during the third and fourth decade of life. The disease is there since childhood, but the usually presentation is in the third and the fourth decade. Early diagnosis and treatment may delay development of end-stage kidney disease. 8 to 10% of patients on ESKD on dialysis are due to autosomal dominant. Almost 8 to 10% of patients who are on maintenance hemodialysis, they are suffering from autosomal dominant polycystic kidney disease. A normal kidney and a polycystic kidney. Autopsy report of a polycystic kidney disease, irregular shaped kidney with prominent cyst in it. Now, the clinical features of ADPKD, the patients are usually asymptomatic until the third and fourth decade of life. And before that, it is usually an incidental finding. The most common initial complaint is abdominal and flank pain. The pain is dull in nature, continuous and dragging. These all symptoms are basically because of the enlarged size of the kidney. The size of the kidney can reach up to 17, 18, 20 centimeters. May present with renal colic because of bleeding in the cyst, clot formation, infection, or stone disease. Recurrent gross hematuria due to cyst rupture may be a presenting feature. Headache is common. There is another reason for this headache. There may be a positive family history and may present late with signs and symptoms of advanced renal failure. On physical examination, hypertension is invariable. The abdomen is protuberant. The palpable flank masses, palpable kidneys are usually are palpated. There is hepatomegaly, which is nodular with polycystic liver disease. And then there are the features of uremia like anemia, pallor, dry skin, acidotic breathing, fever, malnutrition, etc. All the features of uremia. The renal complications include hypertension, which is common in 80% of the cases. Gross hematuria can occur in 50% of the cases because of the cyst rupture. Stone disease is quite common because of stasis, resulting in uric acid stone or calcium oxalate stone almost equally. Cyst can get infected, resulting in sepsis and chronic kidney disease, leading to end-stage kidney disease in 50% of the patients by the age they reach 60 years. Now, what are the important extrarenal manifestations of autosomal dominant polycystic kidney disease? There may be cyst in the liver, multiple hepatic cysts in almost 70% of the cases. Cyst may also occur in pancreas, spleen, ovaries, and testicles. Cardiovascular complications include arterial hypertension, heart valve defect, that is one of the important one is mitral valve prolapse, aortic and tricuspid regurgitation, and left ventricular hypertrophy because of long-standing hypertension. The GI external manifestation include colonic diverticular, and just because of the sheer size of the kidney, there is abdominal and inguinal hernias. In CNS, cerebral perianeurysm is common in 10% of the patient. It arises in the circle of the villus and can lead to catastrophic CVA with subarachnoid hemorrhage. They can have thyroid cysts, they can have renal cysts, and they can have cardiac abnormalities. We have already discussed abdominal hernias, intracranial aneurysms, intestinal diverticula, hepatic cyst, pancreatic cyst, and aortic aneurysm. These are the extrarenal manifestations of autosomal dominant polycystic kidney. This is a normal heart with normal mitral valve, atrium, and ventricle. This is a heart with a mitral valve prolapse. Whenever there is a ventricular contraction, the mitral valve prolapses into the left atrium. normal mitral valve, left ventricle, and other chambers of the heart. Whereas in left ventricular hypertrophy, there is hypertrophic left ventricle, which is called LVH, left ventricular hypertrophy. Colonic diverticula, colons, showing diverticula, they can present with lower GI bleeding, or they can also have severe constipation. Now, perianeurysm on the anterior communicating artery of the brain, this is circle of Willis, and these aneurysm, when they rupture, can lead to subarachnoid hemorrhage. How do we diagnose autosomal dominant polycystic kidney disease? Most of the time, there is positive family history. Somebody in the family had polycystic kidney, like parents, brothers, or sisters. Laboratory investigation, we can easily diagnose polycystic kidney disease with ultrasound, CT, MRI, and IVP. The most favored and the most commonly used ultrasound, it is economical. And finally, genetic testing is usually performed in rare cases. In laboratory investigation, these patients, it is one of the important cause of chronic kidney disease in which erythropoietin is produced. In most of the patients of chronic kidney disease, they are anemic because of lack of erythropoietin. It is one of those diseases, polycystic kidney disease, in which hematocrit is maintained or may be increased because of increased erythropoietin. As we know, the erythropoietin is produced in the interstitium, and there is elongation of the interstitium in the polycystic kidney disease, resulting in a more production of erythropoietin. Urine analysis may show hematuria, proteinuria, and low specific gravity. Urea creatinine electrolytes are raised, added, signifying renal failure. Again, calcium, phosphorus, alkaline phosphatase, and PTH are raised, showing chronic kidney disease. Uric acid is usually high in chronic kidney disease, and urine culture are usually positive because of a common UTI. UTI is quite common in patients with polycystic kidney disease. Ultrasound is a treatment of is a gold standard, is the investigation of imaging technique of choice. Ultrasound is a procedure of choice, gold standard. It can detect cysts up to 1 to 1.5 centimeters. The benefit of ultrasound that it is easily available and it avoids radiation and contrast. It is inexpensive, readily available, can be easily performed, shows enlarged kidneys with multiple anionic cysts, bilaterally of varying size and increased density of parenchyma. Ultrasound showing cysts in the kidney of varying size. Again, the ultrasound showing cysts in the kidney. Now, the other thing, other imaging technique which can be used is computed tomography, CT scan. It is more sensitive than ultrasound, can detect cysts up to 0.7, centimeters, which helps in the early diagnosis. It is useful in doubtful cases and in children in whom you are suspecting polycystic kidney disease. Useful in complicated cases like kidney stones and suspected tumor. But the problem is there is exposure to radiation. It is more expensive. And on CT, you will find well-defined round and oval masses with low attenuation. Now, this is a CT scan showing multiple cysts with clear fluid in it. MRI can also be used in the diagnosis of polycystic kidney disease. Is more sensitive than both ultrasound and CT scan, but it is very helpful in the diagnosis, in the differential diagnosis of renal cell carcinoma, which can develop in the cyst and which is again a differential diagnostic tool. Cysts are homogeneous and thin-walled. Cysts do not enhance on gadolinium, which is the dye which is used in MRI. This contrast is very nephrotoxic and can precipitate renal failure. So before advising anybody MRI, we have to take certain measures, especially in patients with uh, impaired renal function. They need to be hydrated adequately. This is a polycystic kidney with renal cell carcinoma. different varying size cyst, but this cyst is showing an enhancing mass, which is most probably a renal cell carcinoma. Intravenous pyrography is nowadays rarely used in the diagnosis of polycystic kidney disease. Again, the contrast may precipitate renal failure. It may be used to evaluate presence of obstruction due to stones in renal pelvis or cystic obstruction. The better option is CT pyelogram, in which no dye is used, no contrast is used. In fact, CT pyelogram is available very easily these days, and IVP is almost abundant. Exfiltratory urogram, and this is radiology of intravenous pyrography. Circle marks sites of cystic dilatation, deforming the renal collecting system. These are the calyces. In a 40, one, you have to note the Kelvin configuration of the dilatation of the renal pelvis. Genetic testing, as I said, is rarely performed. DNA screening for polycystin PK1 and PK2. It is not routinely performed. It is expensive. Here I have written $3,000, but it is basically more than $10,000 now. It is useful when the diagnosis is uncertain on imaging. If there is a family history of polycystic kidney disease and they want to donate kidney, younger than 30 years with family history of PKD and the ultrasound is negative. In such situations, it can be ordered, can be done, but it is rarely performed. You have to do a DNA screening for PK1 and PK2. Now, how do we manage autosomal dominant polycystic kidney? The primary aim is to delay the progression of CKD to ESKD. We have to, and how it can be achieved? It can be achieved with strict control of blood pressure with ACE and ARB, low salt diet, weight control. We have to avoid nephrotoxic drugs, protein intake in moderation, have to avoid hyperkalemia, and fluid intake as per urine output. These are few of the measures which can help in delaying the progression of chronic kidney disease or autosomal dominant polycystic kidney disease. If there is infection, you have to treat the urinary tract infection. Hematuria, fluid intake, and rest. Painkillers usually self-limited. Reduced abdominal pain, avoid NSAID, use spasmolytic. Nephrectomy is rarely performed in patients with polycystic kidney disease. It is a last resort, but is usually not performed. End-stage kidney, once the patient develops end-stage renal disease, we have got no option except for renal replacement therapy, which is required in almost 50% of the patients, maintenance hemodialysis, or they can have kidney transplant, which is the treatment of choice. So in conclusion, almost 50% of patients with autosomal dominant polycystic kidney disease develop end-stage renal disease requiring renal replacement therapy. The target is to delay the progression of CKD to ESKD. No specific medication is available at present. There are certain clinical trials which are being conducted on veptans. So veptans are vasopressin antagonist, which receptor sites in the kidney which accepts vasopressin, they block it. So there is too much of excessive diuresis resulting in the shrinkage of size, but it still is not FDA approved and is in the trial, clinical trial basis. Veptans are usually used for the treatment of hyponatremia. Control of blood pressure with medication and healthy lifestyle. Screening of siblings, especially family history, is important. And if you diagnose somebody with polycystic kidney disease, it is advisable that other family members should also be investigated for the presence of cyst. Genetic counseling is important. Cerebral aneurysm, cardiac complications, hepatic cyst, and infections are poor prognostic indicators. This was about polycystic kidney disease, and one other important tubular disorder is the urinary tract infection. This is basically a combined disorder dealt by both urologist and nephrologist. So I'll be taking urinary tract infection in a next lecture. Thank you very much.